I'm so grateful to the Ovarian Cancer Research Alliance for the opportunity to speak to you about a topic that's close to my heart. And I want to start by recognizing the range of experiences that I expect the audience will bring to this session, and recognize that what we have in common certainly is caring about people impacted by ovarian cancer. My name is Carolyn Lefkowits. I'm a GYN oncologist and a palliative care doctor at the University of Colorado. I was the first GYN oncologist nationally to be fellowship trained separately in palliative care, and I'm very proud of that. In my clinical work at the University of Colorado, I do primarily GYN oncology, but also have a separate palliative care clinic where I see patients with any type of cancer to provide palliative care. I refer my own GYN patients to our palliative care clinic to see my palliative care colleagues. That's how important I think it is for patients with cancer and their families to have a separate dedicated palliative care team as part of their cancer care. So I titled this talk, Palliative Care Integration in Ovarian Cancer, and not or, because I want to really change the historical conversation about palliative care and cancer from talking about cancer treatment or palliative care to cancer treatment and palliative care. Historically, I think the perspective in oncology has been, or had been anyway, that you can have either aggressive anti-cancer therapy or palliative care. And what I'm going to try to convince you of today is that we really limit ourselves when we think women with ovarian cancer stand to benefit dramatically if instead of offering anti-cancer therapy or palliative care, we offer anti-cancer treatment and palliative care. So not or, and. My objectives are that by the end of this session, you would be able to define palliative care and differentiate it from hospice or end-of-life care, list at least 3 evidence-based benefits of palliative care for people with cancer, differentiate between what we call primary and specialty palliative care, and I'd like you to leave with homework. And that homework will be to familiarize yourself with the palliative care resources available to you wherever you are. We'll start by talking about what palliative care is and isn't, and then do a little sidebar on advanced care planning because I think it's so very important. Then I'm going to review some of the evidence supporting the integration of palliative care into cancer care or why we need it. Palliative care can be delivered in lots of different ways, so we'll talk about some of the ways you can get it, how can you get it. We'll go over some barriers to palliative care integration, and then talk about next steps toward improved integration of palliative care into the care of people affected by ovarian cancer. So what is palliative care? You may read lots of different definitions out there. The definition on this slide is from the American Society of Clinical Oncology, and I'm going to go ahead and just read it. Palliative care includes therapies that address the multiple issues that cause suffering for patients and their families and impact their quality of life. And just to dispel upfront a common misconception, palliative care is not synonymous with end-of-life care, and it can absolutely be offered concurrently with surgery, chemotherapy, radiation therapy, including when the goal of that therapy is cure. Here's another definition that I like. This one is from the Center to Advance Palliative Care. And again, I'm just going to go ahead and read it. Palliative care is specialized medical care for people living with a serious illness, like ovarian cancer. It focuses on providing relief from the symptoms and stress of a serious illness. The goal is to improve quality of life for both the patient and the family. It is appropriate at any stage in a serious illness and can be provided along with curative treatment. So in short, palliative care serves as an extra layer of support for women and their families living with ovarian cancer. That phrase, extra layer of support, is one that comes actually out of a public opinion survey done by the Center to Advance Palliative Care, where they found that the majority of people did not know necessarily ahead of time what palliative care was, and we'll talk more about that later, but once it was explained to them more at length, this short phrase sort of resonated with people, and so I use it frequently in explaining palliative care, both to patients and to colleagues. So our first objective was that you would be able to define palliative care, and I think the easiest definition to remember is that it serves as an extra layer of support. Here, I just want to highlight the relationship between palliative care and hospice care, which is that they have an overlap in terms of a focus on comfort and quality of life, but distinctions in essentially eligibility. So what they share is a philosophy of care centered on comfort and quality of life. Where they differ is that palliative care can be offered alongside cancer-directed therapies, including when the goal is cure, as I mentioned, and is appropriate at any point in the disease course for a serious illness like ovarian cancer. Hospice, on the other hand, is essentially, at the end of the day, it's essentially an insurance benefit that has an eligibility requirement of a prognosis measured in months and is provided primarily at home and cannot be offered concurrently with other cancer-directed therapies like chemotherapy. And just while we're on the topic of insurance, sometimes the question comes up about whether palliative care services, such as we'll be talking about, are covered by insurance. And the answer is generally yes. Most insurance plans, including Medicare and Medicaid, do cover palliative care services. So just to get a bit more concrete, sort of down in the weeds about what palliative care is and what clinical services it provides, this slide contains the 9 domains of palliative care outlined by the American Society of Clinical Oncology and the American Association of Hospice and Palliative Medicine. So they say that palliative care includes symptom assessment and management, psychosocial assessment and management, spiritual and cultural assessment and management, communication and shared decision-making, and these conversations may include discussions of prognosis or advanced care planning, or just conversations at sort of decision-making branch points in care where we're choosing between multiple options or figuring out how to best match that individual patient's values and goals to the treatment course that we choose. Number 5 is advanced care planning. As I mentioned, we'll do a little sidebar about that, a detailed discussion about advanced care planning. It is kind of beyond what we have time for today, but certainly critically important in the setting of a serious illness such as ovarian cancer, that their loved ones and medical team really have a sense of what the patient would want for their care if they were suddenly unable to speak for themselves. Number 6 is coordination and continuity of care, and this can be helping to coordinate a clear message for patients who have multiple services involved in their care. Also includes helping patients navigate the healthcare system. So, for example, helping to match services available at a cancer center to that individual patient and family's goals and values. Number 7 is appropriate palliative care and hospice referral. So here, palliative care refers to specialty palliative care services. We'll discuss that more later, but not all palliative care services can or even should be delivered by palliative care specialists. The oncology team will often touch on or address several of these domains in the course of standard oncology care. Number 8 is carer or caregiver support. And number 9 is end-of-life care. So end-of-life care falls under that broader umbrella of palliative care, but really represents only one section of sort of the full scope of what palliative care services can provide. So we talked in generalities about palliative care domains, but often patients and families will be curious about if we go see a palliative care provider, either as a consultation in the hospital or an outpatient clinic, like what actually happens in that visit. And so that's going to vary from patient to patient, depending on their needs within those multiple domains of palliative care. But to give you an idea, this is some data that comes out of kind of the landmark or first big study of palliative care integration in cancer, which I'll tell you about. It was in lung cancer patients. But broadly, they outlined kind of what happens at these palliative care visits. So looking at 67 patients with advanced lung cancer, their first palliative care visit in the outpatient setting ran about an hour in length. About 20 minutes of that was spent on symptom management, about 15 minutes on average on patient and family coping with illness, and about 10 minutes on illness understanding and education. So that might be some of the distribution of what might happen on average in a first palliative care visit, touching on some of those domains that I mentioned. The next question is, when in the disease course is it appropriate to integrate palliative care? And I would say the short answer is anytime, and the earlier the better. This is sort of the old model. So this is from a curriculum about palliative care in cancer, showing that in the older model, we thought about anti-cancer therapy and palliative care, mostly hospice care, as almost like mutually exclusive. You did one and then the other. So a patient might receive treatment for her cancer, surgery, maybe chemo, maybe some radiation, until that time at which we kind of are out of treatment options for the cancer, or the patient is too sick to get any of those treatments anymore. And then there's like a line in the sand, and hospice or end of life care begins. And I would say that is an outdated way of thinking at this point, and would encourage all of us to leave that in the rearview mirror and adopt a new way of thinking, represented more by this. Or there's a bunch of different pictures you can see, some sort of go up and down with amount of palliative care over time. But point being that there's a role for palliative care integration from much earlier in the course of an illness like ovarian cancer. There's no reason that care focused on the relief of suffering needs to wait until near to the end of somebody's life, or needs to be limited to cancer patients whose lives will end due to their cancer, right? So now we're thinking about all patients that have a serious illness like ovarian cancer, including when the goal of their treatment is cure. So more recently, there's been more of a push to integrate palliative care earlier in the course of illness and offer it alongside cancer-directed therapies. So here, we have supportive or palliative care essentially from the time of diagnosis. And sometimes you'll see the term supportive care used interchangeably with palliative care. The time around diagnosis can be a time of high need, as I'm sure lots of folks have experienced, between the symptoms from the disease, the need for assistance with coping, and then the degree of involvement of supportive or palliative care can really wax and wane according to the patient and family needs. If we're in a place where the illness continues to advance and someone's prognosis becomes shorter, time may be limited, the focus of care can shift gradually rather than suddenly, and ultimately may be completely focused on comfort. That may involve utilization of hospice services. And then in this model, and in the hospice model in general, care continues beyond the death of a patient as bereavement support for the patient's family, which is so critical. Notice that we talk here, or I try to use language around transitions in care and shifting of focus, and not ever talk about stopping treatment. Because even if we stop treating somebody with chemotherapy, for example, even if we stop treating the disease itself, we don't stop treating the patient. We don't stop treating the family and caring for them. We may treat them with a different focus, but we continue to treat them. So in summary, palliative care is both a philosophy of care and a set of clinical services appropriate for any patient with a serious illness like ovarian cancer that focus on quality of life for the patient and the family. As shown here, this is also from the Center to Advance Palliative Care. Palliative care can help patients and families do a range of things to improve their quality of life and the quality of their care. So at the beginning, I told you I was going to do a little sidebar on advanced care planning because it's so essential to navigating a cancer journey. So we're going to do that. Here it comes. So this is a public service announcement. I think that no talk about palliative care to patients and families would be complete without making a plug for the importance of advanced care planning. Broadly, advanced care planning means making decisions about the care that you as a patient would want if you were unable to speak for yourself or make decisions for yourself. So that includes designating who your medical decision maker would be, or sometimes called medical power of attorney. If you couldn't speak for yourself, who would speak for you in terms of medical decisions? And then outlining preferences for your care if you were to become critically ill and unable to express those preferences for yourself. And it can be hard to talk about, and often doesn't feel like the most pressing thing in any given moment, especially when people are feeling well. And I would say there's no greater gift that a patient can leave to their family than having done some of this work and outlining preferences for themselves, because it's the difference between a family. If they face a scenario where somebody can't speak for themselves, that family is left to carry out decisions that the patient has made for herself rather than trying to make decisions for her. And the weight of that for a family can feel very different. And I've seen just such great relief in families who are in a place where they are carrying out decisions that they know this is what their loved one would want because she told them. So one structured way to express some of these preferences for your care as a patient is through completing a 5 wishes document, which walks you through answering 5 questions: who you would want to make healthcare decisions for you. So that's the MDPOA that I mentioned. What kind of medical treatment you think you would or would not want. How comfortable you want to be or how you want to be comfortable, how you want to be treated, kind of anything else you would want your loved ones to know. And as I mentioned, understandably, people can be hesitant to engage in some of these conversations. And I think doctors and nurses and nurse practitioners, PAs can be hesitant to bring it up. People understandably don't like to think about the possibility of a time when they may not be as functional as they are today. But again, as I mentioned, it can be a huge gift to your family to leave them to carry out decisions that you've made for yourself, rather than be trying to make decisions for you. And then just to have examples, here's another structured way to go about initiating advanced care planning discussions. You can order online at gowish.org something called Go Wish cards, and they each have something printed on them that may or may not be important to you as an individual, particularly if your time was short. And they're designed for you to be able to sort them into categories of things that are very important, somewhat important, not important. And it's something that the whole family can engage in. You don't have to have a serious illness, to think about some of these things or to have benefit from having articulated some of these preferences for your family. So it's really relevant to everybody. Sometimes people can be hesitant to talk about advanced care planning. Almost they're afraid that talking about it makes it more real, or somehow means they're going to be so sick that they can't make decisions for themselves in the near future. And I want to encourage us to think about it like a seatbelt. So it's like putting on a seatbelt when you get in the car. Putting on the seatbelt doesn't indicate that you think that you're going to get into an accident, right? It certainly doesn't cause you to get into an accident. It just represents a reasonable precaution to take in the case of a worst case scenario. When you think about it like a seatbelt, it seems almost foolish not to do it, right? Given what we know about the risks of riding in a car. And I think the same is true with advanced care planning, just in general. I mean, not even limited to patients with cancer. That failure to do so while you're feeling well enough to engage in thoughtful discussion with your family is really a missed opportunity. So think about it like a seatbelt. Okay, sidebar finished about advanced care planning. We get back on track. So before we go into why we need palliative care, just to review the what, palliative care serves as an extra layer of support to patients and families facing serious illness like ovarian cancer. It can be offered concurrently with disease-directed therapy with the goal of improving quality of life. And this distinguishes it from hospice care, which is available only to patients with a limited prognosis or who are no longer pursuing disease-directed therapy. Palliative care includes, among other things, symptom management, assistance with patient and family coping, and efforts to improve illness understanding, as well as facilitation of advanced care planning. So why do we need palliative care? In summary, because high quality research and evidence shows multiple benefits to both individual patients and families and the healthcare system as a whole in providing truly high value care when we include palliative care in ovarian cancer care. So I want to review some of the evidence behind that assertion. I know that this is an audience that stays very up to date with the research in ovarian cancer. And I think that that is a great way to be empowered in your own care and the care of your loved ones. So let's review some research related to palliative care. Let's talk about the benefits. This is an older kind of summary paper, and these benefits have only been further reinforced in a variety of other studies since that time, but there have been multiple studies showing benefits of palliative care with respect to quality of life for patients and families and caregivers, reduced pain and other distress, improved health-related quality of life, high patient and family satisfaction with care. For patients who ultimately die of their illness, patients who have had involvement with palliative care specialists are less likely to die in the hospital, which is generally where most folks do not want to die. They are more likely to die at home or in another location that they prefer. Palliative care involvement is also associated with a reduction in hospital length of stay and an ICU length of stay. The question of how, if at all, palliative care involvement impacts survival time is a somewhat contested hot topic. At the very least, all of the comparative trials that involve palliative care interventions have shown no decrement in survival, no worsening of survival. So we're not shortening, we know we're not shortening people's lives by integrating palliative care into their cancer care. And I mention this because I think it's a pretty common fear, both for patients and sometimes for providers. What if the palliative care providers just talk everybody into enrolling in hospice? But that's not how it works. And the data and the research that we have bears out the fact that palliative care does not shorten survival. There are a couple studies suggest it may prolong survival, but it certainly does not shorten length of life. Okay, so I mentioned this earlier. This is sort of the landmark study of routine palliative care integration in cancer care that I think really elevated the awareness in the oncology community of the benefits of palliative care delivered alongside standard oncology care. So this was 2010, I believe. These patients had lung cancer, not gynecologic cancer. But I think the principle is the same, is can we deliver palliative care alongside cancer care and improve people's quality of life without worsening their survival? So these patients had stage 4 lung cancer, and they were randomized. So half of them got standard care, which could have involved palliative care referral, but not in any sort of structured way. And then the second group had routine palliative care involvement in the clinic, in the outpatient setting, from the time of diagnosis. So those patients would see palliative care about once a month. So it was not a trial of palliative care or no palliative care. It was a trial of routine palliative care where the oncologists could send somebody to the palliative care clinic if they wanted to, for whatever reason at any time, versus the routine palliative care group got palliative care from the time of diagnosis with regular visits. And they found that the routine palliative care group had better quality of life. This was what called the primary outcome of a trial. This is the thing it was primarily designed to look at. They had less depression. For the patients who died, they had less aggressive care at the end of their lives. And this is often used as a marker of quality of care near the end of life. We know that in somebody's final weeks or short number of months of life, a lot of the aggressive interventions that can be done in a hospital or an ICU are actually unlikely to extend somebody's time or improve their quality of life. And most patients will say they don't actually want those things nearer to the end of their lives. So this was seen as another benefit of the routine palliative care approach. And this study was not designed to look at overall survival, but not only did the routine palliative care not shorten patients' lives, the patients who received routine palliative care actually lived longer, statistically significantly longer than the patients who received standard care. And so this is where I think we can confidently say that we are not shortening people's lives with this strategy. As a result of that trial and others, the American Society of Clinical Oncology first issued in 2012 what they called at the time a provisional clinical opinion, recommending palliative care starting early in the disease course for all patients with advanced cancer. So the summary statement was inpatients and outpatients, so folks in the hospital and out in the world doing cancer center visits in the clinic with advanced cancer should receive dedicated palliative care services early in the disease course, concurrent with active treatment. So this was a pretty strong statement for ASCO, not just this is sort of a reasonable option, but this is the preferred path for truly high value, high quality care. In this paper, this clinical opinion was updated in 2017, essentially reaching the same conclusion, but by that time, just with many more studies, trials to back up those recommendations. In 2013, the Society of Gynecologic Oncology, our national society, included palliative care in their what's called Choosing Wisely list, which was a list intended to highlight either overutilized or underutilized services in gynecologic cancer care, they advised not to delay basic level palliative care for women with advanced or relapsed gynecologic cancer, and when appropriate, to refer to specialty level palliative medicine. So I think this really highlights a couple of points. First, that palliative care is an integral part of the care of patients with gynecologic cancer and those affected by gynecologic cancer. And second, so they mention here basic level palliative care and palliative care specialists. And so we're going to talk a little bit more in a minute about what we call primary versus specialty palliative care. But first, I wanted to mention another more recent trial. It was run by the same folks that did that original lung cancer trial back in 2010. And this was essentially asking the question, is it critical that we have this sort of every 4 weeks palliative care visit? That was the structure in the first trial, in part because from a resource standpoint, we don't have enough palliative care doctors to provide that level of intensity of palliative care to all patients who would sort of qualify. So the way this trial was structured was something called a non-inferiority trial. So if you have a treatment option that is either less toxic when we're talking about disease-directed therapy or kind of less resource intensive from a system standpoint, and you want to ask the question, you're not trying to prove that it's better than what you're currently doing. You're just trying to prove that it's not worse, because if it's not worse, it's going to be the preferable option, either because it's got less side effects or because it's sort of less resource intensive or less burdensome to the patients and families. So essentially, they looked at the model that they had looked at before, early palliative care involvement, every 4-week visits, versus what they called stepped palliative care, which honestly, as a palliative care doctor, I will say is more like what we do in real life, which is essentially patients get referred. And then from there, the frequency of their visits kind of depends on what's going on for them. So in this system, they laid it out a little bit more specifically. They said, we're going to see these patients when there's any change in their cancer therapy, or if they've had to be in the hospital, or if their quality of life is going down. So the patients in this study had routine assessments of their quality of life. And if their quality of life was dropping off, they also went to see their palliative care doctor. Again, the primary outcome that they were looking at was quality of life, 24 weeks, so about 6 months into the study. And they did find that this, what they called stepped palliative care, or kind of almost like individualized frequency of palliative care involvement, was not inferior in terms of quality of life. The stepped group did have a shorter length of stay in hospice for patients who died and utilized hospice care, which is generally considered less desirable. Ideally, you want to be in hospice care long enough to get to know the team and have some good quality time at home. The stepped group didn't have particularly short visits, but they were a little bit shorter than the routine group. Overall, I think that this kind of validated or supported what a lot of palliative care clinics and cancer centers were already doing, which is a little bit more of an individualized frequency of involvement. So I think what's important to know is that it means you don't have to be seeing your palliative care doctor or team, every month for it to still be valuable with respect to improved quality of life. And then I wanted to mention the most recent update to this ASCO palliative care guideline that first came out in 2012 and then was updated in 2017. An update was just released again. The overarching message is the same about the importance of palliative care. But I think what the update has to offer that I would highlight is more attention to the critical role of caregivers and the impact that a cancer journey has on caregivers beyond the patient herself. And so the recommendation here was expanded to be oncology clinicians may refer the caregivers of patients with cancer to palliative care for additional support. So I think that's just important recognition of the role of caregivers in all of this. It also talks about the importance of palliative care delivered by oncology clinicians. So I'm going to pause here and sort of mention a little bit more about this primary specialty palliative care distinction that I've mentioned. So primary palliative care usually refers to palliative care, so clinical services, domains that fall within that broad umbrella of what we talked about, symptom management, advanced care planning, care coordination, delivered by the oncology team. So as I'm sure everyone has experienced, the oncology team does a lot of that as part of routine oncology care. Specialty palliative care is palliative care delivered by dedicated palliative care clinicians, usually in a dedicated palliative care clinic. It might be in the same space as a cancer center, might not be, but sort of a separate team that is only addressing the palliative elements. And so think how much primary palliative care, especially palliative care, a patient and family end up receiving depends a little bit about the resources available. And that's again going to be your homework to familiarize yourself with what's available where you are. And also depends a little bit about how their journey is going. More complex symptom management needs, more complex family dynamics or care coordination or system navigation needs are best met by a specialty palliative care team when available. And I think having that extra layer of support when it's available kind of can't lose, no downside. And then I think this is critically important. They've also since published separate resource stratified palliative care guidelines in the Journal of Global Oncology that speak to, in lower middle income countries, what elements of palliative care integration are feasible and how best practices for delivery in those environments. Okay, so how can you get palliative care? So before we go there, just to review, the reason we need palliative care is that it's associated with improved quality of care. It improves quality of life, symptom burden, at worst does not shorten survival, may even improve survival. So how can you get this care as part of your cancer care? Here's a whole dedicated slide to that primary versus specialty palliative care distinction. So again, the sort of domains of care or the scope of what palliative care can cover looks similar. Primary palliative care, specialty palliative care, it's kind of about what team is delivering it. And as such, sort of the level of specific expertise that team may have in some of these palliative care domains. So as I mentioned, primary palliative care is delivered by non-palliative care specialists. So generally in the case of ovarian cancer, the ovarian cancer team, oncology team, though could also be through, say, a primary care doctor. Specialty palliative care is palliative care delivered by dedicated palliative care specialists. So providers specifically trained in palliative care. Often that's an interdisciplinary team that may have a physician, an NP or PA, nurse, social worker, often a chaplain. Specialty palliative care may be available in the hospital. That's actually most common. When a healthcare system has palliative care, often the first setting that shows up in is in the hospital, a palliative care consultation team. Somewhat less common, but becoming more common, is to have outpatient clinics that are dedicated to palliative care. And then palliative care can also be delivered at home in the form of either home palliative care through a home care company or hospice care, like we talked about. The Center to Advance Palliative Care is really a wonderful national organization devoted to palliative care, and their website, which I would encourage you to check out if you have not already, has a bunch of great features, including a quiz called Is Palliative Care Right for You? And spoiler alert, if you have or are affected by ovarian cancer, the answer to that question is going to be almost certainly yes. A searchable provider directory, and then a handout or sort of in PDF form for patients and families called Palliative Care, What You Should Know, which is going to cover a lot of the same points that we've talked about today. So why doesn't every patient and family with ovarian cancer affected by ovarian cancer get palliative care? Let's talk about barriers. In terms of availability, which I alluded to a little bit, there are not enough specialty palliative care providers in the country to provide specialty palliative care to everyone who might benefit from it. There's a lot of talk in the specialty palliative care community about how to really target the available specialty palliative care to patients who will most benefit from it. Sometimes I worry that the specialty palliative care community jumps almost too quickly to the solution that more palliative care should be primary palliative care or more should be delivered by the oncology team. Because I really think if what we're asking for is increased attention to an element of the care of women affected by ovarian cancer, families affected by ovarian cancer, namely the palliative care element by the oncology team, we somehow have to increase that team's capacity because, as you all know very well, your oncology team is, already probably working to fit into your appointment time all of the things that they want to cover, some palliative care related things, disease-directed therapy, clinical trial availability. And I think in terms of both education and clinician time, we can't just assume that an oncology provider who's already seeing as many patients as they can fit into a day can suddenly start adding good, high quality primary palliative care into their visits. So I think it's a balance, and some of the studies, like the more recent lung cancer study about this stepped palliative care, I think are moving us in the right direction about how can we distribute the palliative care capacity that we have in a way that doesn't compromise the quality of the clinical benefits that we know it can offer. The next is poor reimbursement. And I didn't go into this today, partially due to time and partially because I think it's far secondary in importance to the clinical benefits. But palliative care has been shown to be more cost efficient at the healthcare system level, again, without shortening or compromising survival or quality of care, in fact, improving the quality of care. Despite that, our current healthcare system model, palliative care services are not well reimbursed, which often disincentivize healthcare systems from building these programs. I'm going to get up on my palliative care soapbox for just 1 second and say that I think if palliative care were a drug that particularly anybody stood to make a big profit off of, given the benefits that we have seen, we would be giving it to every single patient with cancer. I'm going to leave that be. So next is lack of provider education. Oncology providers, historically anyway, have not gotten education in palliative care skills to provide their own palliative care, or may not have been familiar, as some of these studies and even this data wasn't available even a decade ago, as oncologists were being trained about the critical role that palliative care can play in cancer care. And then finally, and this may be the most impactful, palliative care has a branding problem, and we're going to talk a little bit more about that. First, let me say a little bit more about provider education. I think our training as oncologists has, at least historically, and I do think it's getting better, and I'm excited about that, has historically left us inadequately prepared for the role of primary palliative care providers. This was one survey specifically of gynecologic oncologists of over 300 physicians found that less than half felt that their training had helped them relate to terminally ill patients and their families. In that same study, 77% of respondents felt that more training in this area would be helpful. Another survey of GYN oncology fellows, so these are doctors who are in the last phase of their training to be GYN oncologists, they rated the quality and quantity of their palliative care training far lower than other common procedures and oncologic topics. In that survey, about 90% of the fellows said that they felt that palliative care was integral to their training, but only about 10% reported getting that training. And then finally, a survey of GYN oncology fellowship directors, only 14% reported having a written curriculum for palliative care for their trainees. However, encouragingly, almost half said that their program had either an elective or a required palliative care rotation for their fellows. And so I do think that we're moving in the right direction here. And then, as I mentioned, the thing I want to focus on even more is the branding problem. So this is a cartoon. I don't know if the font is big enough to read, but it says, "He's our new palliative specialist." And I think that often the palliative care teams, people think they're the Grim Reapers and that they're the death squad. And we need to do better in branding what palliative care is and what it can offer. So more on the branding problem, this is a study that asked 800 adults in the United States, oversampling older folks. So this is a question not to doctors and nurses, but a question to patients or potential patients. How knowledgeable, if at all, are you about palliative care? And about 70% described themselves as not at all knowledgeable. So this represents an opportunity to brand palliative care, to educate people about what it actually is. Palliative care also has a branding problem with providers, with physicians and nurses who have been shown to lack knowledge of palliative care services and benefits. And the providers often equate palliative care with end-of-life care. And so if providers have that misconception, that gets passed along to patients and families. And in some ways, I think the branding issue with providers is sort of a tougher nut to crack because whereas patients and families may be starting out with a lack of knowledge, and so it's an opportunity to fill in accurate knowledge, providers often have existing misconceptions. And other research has shown that patients, even those with demonstrated unmet palliative care needs, are unlikely to request a palliative care consult, though the vast majority are open to one if their provider suggests it. So earlier I showed you a slide where the term supportive care was used kind of interchangeably with palliative care. Some institutions have taken to renaming their palliative care services or divisions supportive care to try to avoid any negative connotations that patients or providers may have about the name palliative care. They did that at one point at MD Anderson Cancer Center and found, so they sort of renamed their palliative care clinic to supportive care clinic, and they found that their referral rates increased after that name change. So that's something to be aware of. And I think those terms are often used interchangeably. The issue of palliative care and how it is understood or misunderstood is so important that about 10 years ago, the Institute of Medicine, in their broad report entitled Dying in America, concluded that one of the greatest remaining challenges is the need for better understanding of the role of palliative care among both the public and professionals across the continuum of care, so that hospice and palliative care can achieve their full potential for patients and their families. So I do think in the last decade, there's been progress on this front and also still further opportunity for improvement. So when those same people from that earlier survey who started out not at all knowledgeable about palliative care, so about 70%, were informed about what palliative care is using the definition that we talked about at the beginning, including the phrase extra layer of support, they had an overwhelmingly positive reaction. So they were then asked, how likely, if at all, would you be to consider palliative care for a loved one if they had a serious illness? And there were high levels of interest or willingness to consider that. So the public have tended to be uninformed and open to being informed. When they are informed, tend to have a very positive view of what palliative care can offer. So in conclusion, just want to offer some ideas about next steps for optimizing the role of palliative care. I would encourage everybody to familiarize yourself with local palliative care resources at getpalliativecare.org. In discussions with your oncologist and oncology team, it's critical to communicate what's important to you for quality of life, because what that means to people is going to look different. It's very individual. And I think it's harder for your oncology team to prioritize optimizing quality of life without knowing what that looks like for you. I think fostering prognostic awareness is important, and level of interest in detailed information in this regard is going to vary, but within your own preference for information transfer, would encourage you to ask if it's not brought up by the oncology team, kind of where are we at in the big picture? What are the goals of the treatment that we are considering? What's the chance of achieving that goal? And then only when we know those features of a treatment option can we kind of hold those up against the expected side effects, benefits versus burdens. And don't be afraid to request a palliative care referral or ask, do we have a specialty palliative care clinic here at the Cancer Center or accessible for patients in our community? And try it out. Request a referral. If you go and it doesn't feel like it's going to be helpful, you don't have to go back, but would encourage you to at least give it a try. So returning to our objectives, my hope is that you feel comfortable at this point defining palliative care and differentiating it from hospice, listing benefits, clinical benefits of palliative care, integration in cancer care, understanding the difference between primary palliative care delivered by the oncology team and specialty palliative care delivered by a dedicated palliative care team. And then for your homework, I want you to at least familiarize yourself with the palliative care resources near you so you know what's available. And you can do that by asking your oncologist or looking at getpalliativecare.org. And consider engaging, if you have not already, with some degree of advanced care planning, which you can do with or without sort of structured guides like the 5 Wishes document or the Go Wish cards. So take home points. What is palliative care? It's an extra layer of support delivered alongside standard oncology care for patients and families and people affected by ovarian cancer and others. Why do we need it? Because it improves clinical outcomes without adversely impacting survival. How do we get it? Get palliativecare.org or through your oncology team. And when would be, why not now? Because hopefully I have convinced you that anti-cancer treatment can be a combination with palliative care rather than an or. And it's when we combine those things, anti-cancer treatment and palliative care, that we see improved quality of care and quality of life for everyone affected by ovarian cancer. Just to add a couple of extra resources, the American Cancer Society has a website dedicated to palliative care. And actually, the American Cancer Society in the next couple weeks on September 10th is putting on a webinar entitled Empowering Patients in Shared Decision-Making, the State of the Science in Palliative Care for Oncology. So I am planning to attend. I think it's going to be really interesting and would encourage other folks to check it out. And then, as I mentioned, the Center to Advance Palliative Care, getpalliativecare.org. This is a picture of our beautiful medical school campus in Colorado. And thank you very much for your attention. My email is here. Anyone and everyone welcome to reach out anytime. Take care.